We are live now, doctor.
Yeah. Good evening, everyone, and welcome to the second episode of the MOS clinical rounds. And today we will be discussing a very important topic on episcleritis versus scleritis and versus the differential diagnosis. We thought of this topic because there have been a lot of doctors who many times there is a misdiagnosis or a mistreatment or a difficulty in differentiating between these conditions, as well as knowing exactly when to refer, when to escalate, when to start systemic therapy, and so on. And this is something which we commonly see in the OPD. Many times in conferences, it may not be possible to discuss so much in detail, and that is why today we have a very esteemed panel with us, Dr. Radhika Natarajan ma'am, Dr. Sayan Basu, Dr. Parul Deshpande, and Dr. Pranav More as our expert panelists. And to moderate this entire session, we have Dr. Nikhil Gokhale from Bombay, all of whom are excellent and brilliant cornea surgeons. And I think they will take us through the entire gamut of these differential diagnosis and how to go about everything. So, a very big thank you to each one of you for sparing your valuable time and being here. And let's start the webinar now. Thank you so much. Dr. Nikhil, over to you. Please unmute. Yeah.
So I'll share my slides, and at the outset, I would like to thank all the panelists who were really willing to join at the first call, and really appreciate all of you joining. What I thought was that I'll just share with you some of the common cases that maybe I've seen or we see commonly in our OPD, and then we can have question answer session. At the same time, if any of the audience has questions, I'm sure there is some system by which you can either send them to Anaga or to me or one of us or Parul. I'm sure you may be having our numbers, and we'll try to answer the questions as well if possible. So basically, I think one of the big problems or challenges we face as ophthalmologists is that often we are confused what we are treating. Sometimes we refer these to rheumatologists, and the rheumatologist is equally confused because the inputs he gets from us are not very clear, and the treatment of both the entities is quite different. And therefore, it's very important that we learn how to differentiate and how to manage these conditions. So we'll start with a little bit about episcleritis to begin with. So this was about a patient who has had recurrent episodes of episcleritis since about last 5 or 6 years. And as you can see, there diffuse inflammation, which is often sectoral. And typically, I've been trying to treat her with oral indomethacin, lubricants, and cold packs, and she settles down quickly in 4 or 5 days. At one episode, which was having a nodular inflammation, I had to use steroid drops. Similarly, you can have patients who have bilateral active inflammation in the same eye at this in both the eyes. You can also have patients who have more nodular looking inflammation. So as you can see in some of these patients, it becomes difficult to find out how deep is the inflammation. So we would look at discussing how we should be differentiating these conditions. We know that episcleritis is typically benign, self-limiting, and usually does not require a lot of systemic immunosuppression, etc. So we would start with some simple questions to the panelists. Basically, these are some of the questions that I thought we could discuss, and if there are others, we can always add here. Number one would be that how do we diagnose episcleritis and differentiate it from scleritis, as well as differentiate it from some other conditions in the ocular surface problems. Like we get patients who have a little bit of a evolving red eye. Sometimes they evolve into a conjunctivitis. Sometimes it might be a flictenular inflammation, or even an ocular surface disease with a red eye could look like an episcleritis to some of us. You could have an inflamed pingicula, or you could have patients with allergy where there is a sectoral congestion or a granuloma, which might start looking like episcleritis to us. So how do we diagnose it? Some tips from them will be helpful. Other questions being that whether we should evaluate and investigate these patients when they come first time, or if they come recurrent times, what tests we should be doing, how should we be treating them, and when they have really frequent episodes, what should we be doing, and is there any role of a rheumatologist here? So I'll probably stop my screen share and maybe we can have some of these answers. All the panelists are free to sort of comment upon these situations. So first could be about simple tips and diagnosis, or the clinical symptoms and signs that can help us to know this is episcleritis and possibly not scleritis.
Dr. Radhika, ma'am.
Yeah, hi. So I think the lowermost entity in the spectrum would be episcleritis. So if you heard Dr. Nikhil speak, he mentioned the word sectoral a couple of times. So sectoral congestion is probably a small giveaway that we are dealing with episcleritis. Also, for most patients, it will be usually an incidental finding in the sense that apart from the fact it is there, it will not bother the patient very much. Either they come for something else or they come with a red patch in the eye. They usually don't have, any other, even not even a significant discomfort of any sort. And when we examine the patient, especially when we examine outside the slit lamp first, before we examine on the slit lamp, anything on the sclera, I believe, should be examined outside first. You can definitely see that band of congestion, and above and below the episclera and sclera will be absolutely white. So that is one distinguishing factor, the band, the absence of too many symptoms from the side of the patient. And textbook wise, they say that if you see the vessels you can make out, but then for episcleritis you can make out. But if it's scleritis, I believe that the overlying episclera also gets inflamed, so you really cannot distinguish superficial vessels and deep vessels and red vessels and blue vessels, like that, very specifically. And other conditions that mimic episcleritis should be ruled out, like Dr. Nikhil said, a pterygium which will show elastotic degeneration, or even sometimes patients with meibomitis, they can display what I call as catarrhal congestion. They can have a little bit of spillover congestion because the oil is contaminating the tears. So those are things that need to be looked for. Meibomian gland and presence of a pterygium need to be looked for. Otherwise, less symptoms and band-like congestion would be the giveaway for episcleritis.
So sometimes, like one question I often see patients, they tell me that their eyes have been red and they've been to several ophthalmologists and now they're putting steroid endlessly, and they come to you with a white eye. So when I see there's nothing, I tell them I can't see anything, but they're on steroids, and so I sometimes tell them on that maybe you stop steroid, let your eye be red, and then I need to see what it is. And I'm surprised sometimes it is not necessarily episcleritis; it could be other pathologies as well. So how should we approach these type of patients who come, who are on steroids? Sometimes it looks very harsh that you stop everything and then now you come back and I can't diagnose anything. They come with a lot of expectations to a specialist. So any other thoughts on this?
Sayan? Yeah.
Yeah, I mean, that's a very good question. I mean, you're basically trying to differentiate at two levels. The first is amongst all the differentials of an acute red eye and also between episcleritis and scleritis. What for me, I think is the most important differentiator is if the patient, like Dr. Radhika was also saying, symptoms. So the patient at present, when the patient is coming to you, like Dr. Nikhil said, may not have symptoms because they've already been put on steroids, they have a white eye. But if they have pain or if they've had pain, then usually you know that this is deeper inflammation, it's scleritis. Episcleritis doesn't really cause anything other than redness in the eye. It doesn't really cause any other symptoms. There's no watering, there's no pricking, there's no other discomfort. The other thing is initially when they get started on steroids and they come with the redness is less, or their pain also has gone down, they will usually give a history. They'll say that, yes, I had pain, but once I started these drops or I was put on these tablets, my pain has gone down. They'll still have a little bit of tenderness. So pain and tenderness in terms of symptom and sign are, I think, very important differentiator. If you cannot elicit tenderness, if the patient has never had pain, then it's probably not scleritis. And the other thing in terms of examination of the vessels that I think helps is if you want to differentiate along the textbook way of looking at whether the superficial vessels or the underlying vessels, is using a green filter. So if you look at the lesion where, especially if it's nodular and it's very localized in one area, if you use a green filter and look at that area, then it is easier relatively to differentiate and at least to appreciate if there is a hue underneath the superficial. Like Dr. Radhika correctly said, episcleritis is just episcleral vessels which are engorged. In scleritis, both are inflamed, but the underlying, hue of inflammation, which is deeper, and you can see the swelling if you make a slit, it's slightly easier to delineate on a green filter, red
So
free filter.
on history, what particular thing would you ask in the history to be more in for the diagnosis to be more in favor of episcleritis? So no pain and no discomfort is more in favor of episcleritis, is it?
Yeah, episcleritis doesn't have any pain.
Yes. Okay. And what about the response to treatment? So first, when you see such a patient and you have made the initial diagnosis of an episcleritis, what would be your next question to the patient, or what would you do next? Dr. Radhika, ma'am?
So, actually speaking, between you and me, episcleritis is largely self-limiting. Even without treatment, most of the cases subside completely. But then they have no symptoms. They've come only with redness, and you can't tell them, I don't want to treat the redness. So, I believe that the more important factor about episcleritis is the rare involvement of systemic disease. Scleritis is more involved with systemic disease, whereas episcleritis is not. So, first and foremost, I would like to rule that out. Not necessary in the first couple of episodes because it can be a local immunity that is active. But multiple episodes, then you have to get them evaluated systematically. So, rather than the red eye, is there anything lurking underneath after multiple episodes? Otherwise, if it is only the episcleritis, nothing also works. Or like Dr. Nikhil said, you can give oral NSAIDs work better than topical NSAIDs. Also, being a cornea specialist, I am very skeptical about using, topical NSAIDs for a disease that can recur. So that combined with some comfort medication should do the trick.
Okay, so the first 2 times you would not do any systemic investigations. The
No,
third
because
time,
episcleritis is known to be self-limiting and known not to have systemic involvement, as it will be an overkill to investigate, rheumatologically every single episcleritis patient. But after a couple of episodes, you need to kind of, cover your bases that there is no other systemic problem, which could be more threatening than the red eye itself.
what are the percentage of episcleritis patients who would get
Very
recurrent?
rare. Recurrence
Um,
is common, but systemic involvement is rare.
Right, right. So if we have to start the patient on some drops, many people immediately the first thing they do is to give steroid, right?
No, if you
So
have to
what
start
do we?
medication, then with caution, you can start NSAID drops. If there is no corneal epithelial defect or anything, you can start topical NSAIDs also.
Would you actually say no to steroids? What if somebody feels that the patient responds very well to steroids? So what do you do, Dr.
There is a
Nikhil?
thought process, that some people feel that when you use steroids, it tends to increase the recurrence rate. There have been some thought process or publications in that direction. So, and it is self-limiting. So the other problem is that if you give steroid and the patient disappears and keeps using them on and off whenever it becomes again a problem. So sometimes even I've told the patient just hold on 4 days and it goes away on its own as well, with just a little bit of symptomatic therapy with painkiller or with some cold compresses or something like that. So I think I'm not sure, I normally don't give steroid right away. I tell them this is harmless and just hold on and keep observing.
I usually prefer to give steroids if there are multiple recurrent episodes. I think in that situation, patients are very uncomfortable, and that is the time when I tend to go with a low dose steroid in these patients. I don't know. What about the others?
Not in the first episode. You mean
Not in
when the
the first
patient comes with
episode.
the third episode, for example, then you would start a steroid.
Yeah, where you're seeing that the patient is having episode every now and then. So let's say in a year they are having 3 or 4 episodes of episcleritis. Then in that situation, I think I do go ahead with topical steroid.
Dr.
I
Sayan, Dr. Pranav?
I seldom use topical steroid in episcleritis. Dr. Nikhil was talking about the chill compression. They work very well, and it may not be very scientific, but it is very practical in this one condition where you can use cool eye drops actually. They should not freeze it, but if they keep the drop in the refrigerator and use it, could be a lubricant also. The active ingredient may not be working, but the vasoconstriction happens because of the chill eye drops, and that also gives the same kind of relief as any other topical vasoconstrictor.
Okay, okay. But if the patient is not complaining of pain, then giving oral NSAIDs, it's only for the inflammation. Then which
Yes,
NSAID would you give? Yes, which
it's only
NSAID?
indomethacin or anything can be given. Ketorolac, indomethacin.
Combiflam, anything.
Combiflam doesn't, I usually give ketorolac.
So typically, they say flurbiprofen or indomethacin works better. Traditionally, that is a
No, systemically,
orally.
that's okay. Dr. Pranav, is there
Yes,
anything
ma'am.
else would you like
So
to?
I agree with the team here. Most of the not these patients have been referred after being treated. So like what Dr. Nikhil said, usually you'll end up seeing them as a white eye. The only concern these patients have, if no symptoms as such, it's just the redness that keeps bothering, more so cosmetically. They see like redness aata hai, jata hai. So treating it with lubricants, conservative treatment with just lubricants and oral NSAIDs should do the job most often than not. Only when there are recurrences, I think we would like to treat them with low potent steroids. It works pretty well then.
Okay. Then at what point of time would you think of doing systemic investigations, Radhika ma'am?
No, if there are more than 2 recurrences, I send them for systemic investigation. It is just to cover the rare possibility that, see, the logic is this is also an immune disease. It's an immune inflammatory disorder, which could be the tip of the iceberg of any other systemic immune disorder. So if it happens more than a couple of times, I think the teaching itself is that you go ahead and investigate them. But the percentage that come out positive in that investigation for episcleritis is very, very low.
So, Dr. Sayan, what would be the investigations that you would usually ask them to do?
Somebody who has episcleritis only, I would not investigate systemically. Cases of patients who have been referred as recurrent episcleritis, but they actually had scleritis. But like we were discussing earlier, that patient comes with a white eye. They have been diagnosed and treated as episcleritis once, twice, multiple times before, and they present to you with this because they are annoyed about the fact that this is coming and going multiple times. This is usually scleritis that has been underdiagnosed or misdiagnosed or mislabeled as episcleritis. If it is true episcleritis, it's really not something that you need to worry too much about, even if it comes and goes. I've rarely ever encountered episcleritis to be associated. It's usually like post-viral or patient has had, something else and they have this. It can be associated with other, but in itself, it's not something that you get too much worried about.
Dr. Nikhil? Dr. Nikhil, please unmute.
So I'll just share my screen once again and maybe we. So I was just looking up the one. So these are some of the associated diseases. You can see the screen, no?
Yes, yes.
Yeah. So these are some of the associations that have been mentioned. These may be very similar to actually what we see with scleritis, but as Radhika and others have mentioned, these may be less. It may not be, very rarely you'll get anything like this positive. But you need to keep in mind sometimes the investigation may be similar to what you do in scleritis. As soon as you send it to a rheumatologist, they would normally try to rule out a lot of conditions. But basic investigations like rheumatoid factor or ANA and CBC, chest X-ray, a basic workup is what we would do. I don't think we need to do very advanced testing analysis in these type of patients. So we just go to scleritis, which is a little bit more number of slides in this, but we'll go through them a little quickly and then probably discuss. So one of the hallmark of scleritis is severe pain. So typically, unlike episcleritis, patients with scleritis will have very severe pain, which is radiating. Often will wake up the patient in the middle of night. Sometimes they will not be resolved even with analgesics, and it worsens with eye movement. And rarely pain may be absent in the non-inflammatory variants, which we call as the scleromalacia perforans. Vision loss may be there in posterior scleritis. So how we typically classify scleritis is into anterior and posterior. The anterior scleritis is classified as diffuse, which is the most common variant and the least severe. Then we have nodular anterior scleritis, where systemic disease may be present in up to 50% of patients, most commonly again rheumatoid. And then we have scleritis, which is necrotizing in type, which is with inflammation, where you have vasculitic disorders like polyangiitis, rheumatoid, and polychondritis. And then those without inflammation, where we call them, as I mentioned, like scleromalacia. So I'll just show you some of these clinical pictures so that we are able to diagnose what type of scleritis we are seeing. So as mentioned here, rheumatoid arthritis accounts for about 8 to 15% of scleritis cases. So it's one of the most common associations for scleritis patients, and about 2% of rheumatoid patients may develop scleritis. So as we were discussing, a red free light evaluation and even trying to see these patients in the daylight might be useful to us to know where exactly is the congestion. So typically on the surface of the eye, we have a conjunctival plexus, which typically gets blanched quickly, even if you put dilute phenylephrine. Then you have the superficial episcleral plexus, which will sort of again blanch to some extent with 10% phenylephrine. And then you have the deep episcleral plexus, which typically will not get blanched by phenylephrine. So in patients with scleritis, some of these deeper inflammations, the redness will not really go away when you put phenylephrine. So there will be some amount of congestion that will still remain there. So there have been classifications of scleritis which are based on blanching with vasoconstrictor. So they've tried to classify scleritis as grade 1, 2, 3 based on how much of blanching was there with the vasoconstrictor, as well as what is the pattern or vascular pattern that needs to be seen. Because, for example, patients with necrotizing scleritis have ischemic pathologies and necrosis, where you'll see a vascular dropout. So I just like to maybe pause for a minute and say whether if anyone is trying to really use these systems in clinical practice, or it's more of just a textbook sort of information. Because the severity of scleritis for me is not really based on the blanching pattern, but if anyone else would like to comment on this. So anyone is using this type of a system to, there is an article which says, that you can grade it.
I'm not using it. Neither am I using the phenylephrine also, because most of the times when you see a deeper edema, you're very sure it's the scleritis. So I've not used phenylephrine very often in my practice.
Right. Okay. So I'll just show you some of the pictures of various types. So a diffuse scleritis is what you see, and a nodular scleritis, you'll see a raised nodule which lifts up the vascular plexus and the surfaces. It looks like a bump. And then normally when you treat these patients, there is some resolution, as has been seen in these pictures, that the patient was improving. You can see the congestion goes down, the elevation goes down. And then you have patients who have necrotizing scleritis, which is a much severe form of scleritis, it's quite ominous and requires more aggressive treatment, where you might start seeing scleral nodules. You might see areas of scleral thinning and uveal show, and sometimes some of these patients may also come with staphylomas. So typically these type of necrotizing scleritis are common in patients who have vasculitic disorders like Wegener's granulomatosis. So they'll have severe, as you can see, there is an ulceration of the surface. UVL show is there. Some of these patients with Wegener's will also have a peripheral ulcerative keratitis, and they progress very fast and they need very aggressive treatment. There's another patient's eye with necrotizing scleritis, which was, and typically these patients, we do an ANCA test, which is anti-neutrophil cytoplasmic antibody, which is positive. There are P and a C ANCA test, which is done. And if these are positive, of course, they need rheumatology evaluation and management. This was again a patient who came to me, and this looked like a granulomatous lesion on the superior bulbar conjunctiva. I thought this looks with an abnormal vascular pattern. I thought this is an ocular surface neoplasia, which is quite extensive, and I sent them to LVP, and they did a biopsy, and the biopsy showed it was just inflammatory in origin, and then subsequently an ANCA test was done, and he was put on immunosuppression, and you can see the pictures below. Within a few days, the lesion had nearly melted away. So they can have a very unusual presentation at times, which are confusing for us. Another form of necrotizing scleritis that we may sometimes see in our practice is called surgically induced necrotizing scleritis. This can happen after any ocular surgery and can happen many years or even decades after the surgery. And most of these patients will have some underlying autoimmune disease. And they again have a vasculitic origin, and they require immunosuppression for these patients. So for example, this was a patient who had a pterygium surgery without mitomycin C and had scleritis away from the site of the surgical site as well, and at multiple places, quadrants, which was very suggestive that this was not exactly anything related to the mitomycin, which was although not used. And this patient did well with the complete resolution of inflammation with immunosuppressive therapy. This patient was also positive. So many of these will have a systemic autoimmune condition which is associated along with. And this was another patient that I saw this patient who had a history of a long-standing rheumatoid disease which was not being treated. And the patient had a red eye for about 15 days after surgery, which was diagnosed as scleritis. And her test for autoimmune condition was positive. So the patient was started on steroids, which was stepped up. However, the patient continued to worsen with scleral necrosis. And at that time, a diagnosis of surgically induced necrotizing scleritis with connective tissue disorder was made. Patient was sent to a rheumatologist and then came to me for a second opinion. And when I saw the patient, there was extensive necrosis with what looked like a thick discharge. So I decided that I would rather scrape it first rather than treat it with further immunosuppression. And we got Pseudomonas in this particular patient. And then we treated him with antibiotics systemically as well as topically for many weeks, more than a month. And over a period of time, the eye has resolved. The patient's vision is still about 618, but there are staphylomas, but the sclera is holding on. So I think the message I had was that sometimes you have patients who have an autoimmune disease and we jump to a conclusion of an autoimmune pathology, but they can have even an infective or some other way by which they can develop a scleral inflammation or any other pathology could coexist. So it's sometimes not wise to just jump to a conclusion because the patient was RA positive that this is immune mediated. So these you can have masquerade situations. And as maybe Dr. Radhika will also like to share, she said on infectious scleritis, very often there may be a history of trauma or a surgery, which is sort of an exogenous pattern of infectious scleritis, where these patients have multiple pus points. They may have conjunctival ulceration over these pus points, and discharge may be present. Some of these will have ulcers and hypopion, and usually these patients will initially might show some response, but they over a period of time start worsening when you give systemic steroids or immunosuppression. This was another patient who had a tunnel infection due to aspergillus, with the wound getting infected with a scleritis, and over a period of treatment of time with just medical therapy, we were able to salvage the eye. And there are also patients who have severe late onset scleral ulceration and scleral infection because of Pseudomonas. following pterygium surgery, and this is a well-described condition where you can have decades later infection with Pseudomonas in patients who have undergone pterygium surgery because of some alteration in the scleral anatomy, which causes the infection to spread rapidly through these channels. And this was one of the patient of mine where during the COVID pandemic, I couldn't really do much with this patient, but I tried my best. But he had an acanthamoeba ulcer, which came in an advanced stage, and acanthamoeba and these type of organisms can cause scleral involvement. Whether it's infective or immune mediated is another question, but over a period of time, the eye was practically destroyed, the sclera was thinning, and there was uveal show. This is, of course, patients where you have scleral inflammation with no active inflammation, but they get scleral thinning and progression. Posterior scleritis is often misdiagnosed or not picked up because you need to do a B scan. Very often these patients may present with choroidal folds or a subretinal mass lesion or disc edema, vision loss or a choroidal detachment, and on the B scan you can see fluid in the posterior Tenon capsule. And then you can have patients, as I said, with scleral involvement with corneal involvement, typically again with Wegener's, or in inflammatory bowel disease and so on. So maybe I'll just share the next 1 or 2 slides and then we'll have questions again. So there are a host of disorders that can be associated with scleritis. So very briefly, about 50% you may not find any positive testing. In about 40% there may be autoimmune disease, maybe infections in 5 to 10%. Some of these patients may already be having a diagnosis of autoimmune disease. Some of them will be diagnosed when you investigate these patients. And some of these patients may be negative, but may develop the disease subsequently on subsequent follow-up over a period of time. We need to understand that necrotizing scleritis is severe, has basically analogous to systemic vasculitis. And these patients may have a high mortality unless we treat them. So is surgically induced necrotizing scleritis, and infectious clauses. We also need to consider immune mediated pathologies as well as infections directly affecting the sclera, like in tuberculosis, syphilis, herpes simplex, herpes zoster. So we need to rule these conditions out, and sometimes the patients, like with RA, could be immunosuppressed or immunocompromised due to treatment. And when we we forget to rule out an infectious pathology because they're at a high risk of infection, and sometimes the pathology may be due to infection rather than the RA itself. So these are some of the tests maybe we'll discuss, and these are some of the broad guidelines to manage scleritis. So maybe we'll just first discuss a little bit about systemic investigations and then come to the treatment. I'll just stop my slideshow here and maybe just look at some of the questions were that how important is to diagnose scleritis correctly, and the nature of scleritis. Especially we should figure out whether it is a necrotizing or a non-necrotizing variant, and how does it change the management prognosis, what are the systemic workups to be done, rheumatologist referral, when and why, and how do we treat them. So that will come a little later. So we can have some of these first few questions. So I'll just stop share, and maybe I think Dr. Radhika, she wanted to go a little early, but there's still a lot of time. But maybe you can tell us a little bit about your experience on infective scleritis, as you were saying, you wanted to share.
Before that, I should congratulate you on the wonderful documentation of all these difficult cases and the way you've managed them. I mean, for those who manage these conditions know that, to take it from the first photo to the last photo is extremely difficult. So as far as investigations are concerned, I would investigate every case of scleritis, whether it is infective or immune, unless there is a frank reason for the infection, like a surgery or a vegetative matter, thorn injury or something. Unless I'm very sure that, the infection has gone and implanted itself in the sclera, almost all cases of scleritis I will investigate. And the investigation, even though I may start the perfunctionary ones like the RNA, RANA, ANCA, anti-CCP and things like that, I would leave it to the rheumatologist because of late they have an extended panel. So it is only the very superficial parts that we actually know. So I don't think it's right for us to dabble with the investigations entirely on our own. They have a large panel which they titrate to the patient. But that said, some of the tests take some time to come. So if the disease is as extensive as some of the slides that you have shown, then we also cannot drag our feet. After the initial round of results come, or if clinically we are extremely convinced that this is an aggressive form of immune scleritis, I think we should impress upon the rheumatologist to start the treatment, like you rightly said, with pulse cytotoxic agent followed by pulse IV steroid. Without that, it just will not come under control. If we're waiting for the immune panel to come, if we give topical steroid, if we give systemic steroid and drag our feet, we're sure to lose these cases and the eyes as well. So if you see the sclera melting with inflammation, whether or not any test report comes, we have to, the one message that I would like to give is impress upon our rheumatologist colleague that IV cyclophosphamide followed by, both are required, followed by IV steroid should be compulsorily used by the time the test reports are coming. Only then the eye will start quietening. As far as infective scleritis are concerned, there is a lot of difference between the way infection behaves in the sclera and in the cornea. So normally in the context of cornea, we say that, when a problem is bilateral, when there are whitish infiltrates, when there are multiple infiltrates, when it responds to steroid, these are all indications that we are dealing with an immune corneal condition. Whereas in infective scleritis, all these pointers go out the window. Infective scleritis can be bilateral, can have multiple recurrences, can have, whitish kind of infiltrates in the sclera, and infection can also initially respond to steroid treatment. So we cannot use those judging points which we use in the corneal context in infective scleritis. So there has to be a high index of suspicion when the disease is not responding to steroid when it is referred from outside, or if it is actually worsening in the face of steroid, then that is a sure indicator that we are dealing with an infective scleritis. And the commonest being bacterial and Pseudomonas, like you rightly pointed out. And as far as Pseudomonas scleritis is concerned, once it starts coming under a little bit of control, this is one scleritis where after control, steroid has to be used. Without steroid, you will not get resolution completely because inflammatory component is also there, as with Pseudomonas keratitis. HSV and TB are two more entities where, if we are fortunate enough to make the diagnosis along with the antimicrobial treatment, again there you need to use steroids for infective scleritis. But otherwise, I think my message would be that if it is immune, the time is of essence. So the earlier we immunosuppress the patient, the better result that we get. And infective scleritis, we should unlearn and relearn the concepts that we have for infective keratitis in our mind before we handle these patients.
Excellent, ma'am. I think you have really covered it really well. Dr. Nikhil, let me go back to the first thing. Suppose it's a simple case of scleritis. Let's start with that for the benefit of the viewers. Okay, if a patient comes to you, what would you look at in the history and on slit lamp which would lead you to the diagnosis of scleritis?
So basically, most of these patients will come with severe pain will be there. That is, like we said earlier also, it helps us to know that it's not purely an episcleral inflammation. So there is a deeper inflammation. As she mentioned, we also need to look at a history when the patient walks in, whether they have any systemic autoimmune disease, what is the age group of the patient. For example, if you have a elderly patient, then they very often they may have an autoimmune disease already diagnosed. So you look at some of these history. You can look at history of trauma if you are looking at something which may be infectious, or because that is again something which is often comes with a scleritis, and you give steroids and they get worse over time. So in people who are working in agricultural or some sort of thing like that, you can have nocardia or fungus, and injuries can cause scleral sort of ulcers as well. So that is again something that we need to ask. So we need to look at both the immune and the infective etiologies basically.
Then on slit
Then
lamp,
we need to look at,
again,
and then we need to look whether there is scleral necrosis or conjunctival ulceration over the area of the lesion. That is again an important point that we need to know. And we need to look at what is the progression that is there. For example, as the patient had previous episodes, and or are there any areas of thinning that you can see in either eye in some zones, which might tell you that he had some previous issues. Or even if it is the first episode, what is the timeline like? So basically, if there's something which is progressing very fast, we need to act very fast. If there's something which is going on for a month, then maybe we have more time to investigate and to start something and still make a mistake and then still get across it. So some of these things we need to see.
Correct. But on slit lamp, like for example, Dr. Pranav, if you see a patient, for the benefit of our viewers, what would be the sure shot thing that you would see and say that yes, this is scleritis, apart
So
from the
as
history of pain?
Right. As we said that you can see a nice nodular lesion or an elevated scleral. So a red-free filter will let you know how the blood vessels are over that lesion and the hump that you see on the sclera. Definitely on a slit lamp, you can make out it is not related to the episcleral tissue, but it's way deeper. So the hump is quite bigger. In a diffuse scleritis, yes, the pain would be a contributing factor, helping you to diagnose this as a diffuse scleritis, whether you don't have a nodular lesion. And it's important that when you ask the patient for a good history, so chair time tells you that this patient that you're looking at is not just a superficial inflammatory ocular disease, but something emanating from a deeper tissue. So sitting with the patient, asking for a history, digging up for some more information, if there is any systemic associations or not, or any past history of such attacks in this eye or the contralateral eye, would gently tell you something happening at the deeper level. That's how you can make out that this is probably a scleritis issue.
Okay,
Plus,
if the diffuse scleritis,
Sometimes you can even have associated corneal lesions. So that would
yes,
point
that
to
we
that
show.
you are going towards scleritis. You may have an anterior chamber inflammation. So, you're more going towards the scleritis and not the episcleritis.
So in case of a diffuse scleritis, would
Can
it
I add to
mimic?
that a little bit?
Yes, yes.
Can I add to what Pranav said a little bit? So if you want for the general ophthalmologist to be able to diagnose scleritis, apart from all the history that all of them have mentioned, which are very, very appropriate, first and foremost, they must take a look at what is not there. Usually lid edema, discharge, and, conjunctival suffusion are absent in scleritis. So you will have more of a circumcorneal congestion or a deeper congestion in the absence of any discharge or lid edema. They will have photophobia, but usually they won't have lid edema. So we know that there is no ocular surface infection that is happening. And then, we said in the beginning itself, the examination of the scleritis starts outside the slit lamp. You'll be amazed as to how much you can make a holistic diagnosis by looking at the patient when you take them next to the window in your clinic and take a look. So any blue sclera for that matter, not necessarily because of scleritis, is better picked up and examined in daylight. The color, the extent, the patches, and the skip lesions, all that can be found out much more in daylight examination before we bring the patient to the slit lamp. And then the nodularity and the deeper vessel, you can make out scleral congestion very well. They will be thick cord-like vessels, which are totally different from conjunctival or superficial episcleral vessels. Whether the color is violaceous or not is entirely different. But the scleral congestion is definitely thick and cord-like as compared to, the more superficial vessels, which are more, thinner in structure. So these are some of the pointers which can make the a person arrive at a diagnosis of scleritis before they break it down into the severity and the type and everything else.
And regarding the pain, is there any difference in the grade of pain in a diffuse
Yes.
scleritis versus nodular scleritis?
Diffuse scleritis will have dull, boring pain.
And it will be more severe in a
Yes.
nodular scleritis. Okay, Dr. Sain, once you see a patient and you have diagnosed a patient, this is the first episode, not yet diagnosed with any systemic history. What would you start the patient on, the treatment? What would you use the first episode?
For scleritis, scleritis is a very serious condition. It is potentially sight-threatening, and things can go downhill very quickly if it is not managed appropriately in time. So, if my advice would be that, we've had a very nice discussion about how to diagnose the condition. You see scleral inflammation, pain, tenderness, and you've ruled out the other differentials and you've narrowed down on the diagnosis of scleritis. You should send that person to somebody who has experience in managing scleritis. It is not an easy condition to treat because there are so many other associated issues. And if, for example, so to put it very simply, you can treat a patient with scleritis with very intense topical steroids, and probably the patient will get better over a period of 2, 3 weeks, and even the inflammation may subside. But you miss the opportunity of diagnosing the underlying condition which is causing the scleral inflammation. And that can not only result in a delay in appropriate management of the scleral inflammation, which can lead to other problems, like Nikhil showed very nicely, scleral thinning or even melt and loss of the eye, but also, in serious diseases like GPA, etc., where it can be life-threatening. The patient might present it. I've seen patients who initially presented with scleritis and later on presenting with full-fledged GPA with multi-organ involvement. So it's a very serious condition. We should all know how to diagnose it. And as soon as you diagnose somebody with scleritis, I don't think a general practitioner should be treating scleritis on their own. There's no point. It's beyond their brief. They should refer it to somebody who specializes, either a uvea specialist or cornea specialist.
So what
Just
would
go
you
through
start
those
with?
slides, Anaga, and then maybe little bit about basic about a first line treatment. Then we can
First
just
line treatment.
yeah. So I just show you what I have shared.
First line treatment, though, see, I agree with Dr. Radhika that even though infectious scleritis is rare, if you have a necrotizing lesion, if you have an opportunity to take a sample, then you should definitely rule out infection. Mostly scleritis, and especially in the context of if the patient has a scleral buckle or has undergone some kind of surgery earlier, etc., or has had trauma. So, trauma and buckle, I think, are the most common underlying causes for infectious scleritis, especially if there's an impacted foreign body, we should be looked for. Otherwise, if it's not infectious and if you're thinking it's immunological, then these patients need a more deeper workup and more serious treatment. But most of it is anti-inflammatory steroids, etc.
Like I was mentioning, basically, if you have a patient where there is no necrosis that you see, so it is either diffuse or a nodular inflammation, but there is no scleral necrosis at the time of presentation, then you could at least start them on oral NSAID and steroid drops. And if these patients don't get better over time, then you will have to use systemic treatment or systemic immunosuppression. But if you do see scleral necrosis, then there is no point of using oral NSAIDs and things like that. And, you directly have to see a rheumatologist and start systemic immunosuppression.
Just 1 minute.
Yeah.
Sorry to interrupt.
Yeah.
So when you first started with oral NSAIDs
Yes.
and steroids, how
Yeah.
long will you wait before you go on to immunosuppression?
Correct.
What
So,
is that time period?
right.
Is it
So
1 week,
if
1 month?
yes. So if it is a non-necrotizing, that means you're not seeing any necrosis, the scleral architecture is intact, then you can use them for at least 15 days or even up to 4 weeks. 2 to 4 weeks, you can still do a trial. Some people would even switch the NSAID drug to try an alternative NSAID if one doesn't work. Because if there is no necrosis, it's not a medical emergency. Of course, you can investigate and do all those things, but basically you're not losing the structure or losing the eye in that period of time. So and usually most patients initially will start getting better if you give them topical steroid and oral NSAID. But suppose they're not getting better, or they're getting worse, or there is a sort of not adequate response, then you will have to treat them with some systemic further treatment with immunosuppression, as I mentioned.
Okay, one
If
minute.
it is a non-necrotizing inflammation.
Yes, Dr. Parul, which NSAID and which steroid, topical steroid, and how frequently would you give in the first instance? Please unmute, Dr. Parul.
So I usually go with prednisolone acetate eye drops in these patients, okay? As far as the painkillers are concerned, I usually, I'm not very choosy, but I use even Comiflam and give them. But most of these patients who are usually having a very, let's say, a very sectoral diffuse anterior type of scleritis, they usually respond to your topical steroids pretty much, you know.
So
Only
how would you give it? Would you give it for a week, and what would be the dosage? I mean, how frequently per day?
I
1 hour,
start
2
with 6
hours?
times a day dose and then taper, because when you know scleritis and you're not giving oral steroids, you would require a higher frequency of steroid drops. So probably 6 times a day, which I would start, and I, based on the response, I would really taper them. So if I don't see the response, I know it's not going to work, the topical drops, and then that is the situation where you have to go with the oral steroids. So maybe a week or 10 days, I would see with the drops.
So
And
you
if
would
I don't
start
see
with
the
6
response,
times and call the
yes.
patient after a week.
Yes, and if they are not responding, you know, the patient needs an investigation. Patient needs oral steroids. If they are not really getting responded to, only topical drops. Okay, and
Okay,
then
Dr. Radhika ma'am. Okay. So suppose you have started the patient on topical steroids, say prednisolone 6 times a day, 1 week. Okay, and say tablet
responding, then
indolent.
I will taper it down
Yeah.
based on the response.
Would you start advise any systemic investigations on day 1, the first day you see, or you would
It
wait?
depends upon the nature of the scleritis that you are seeing. So
Say,
the
suppose that
only
nodular
case
or
where
a
I
diffuse
probably would not
scleritis.
investigate is diffuse anterior type, which is a very small patch, you know. But if I see a nodular variant or if I see a necrotizing variant, I know we have to investigate that patient. You know, the patient has some amount of systemic immune system problem. So we need to investigate those patients.
In a simple nodular or a simple diffuse scleritis.
So even I think nodular variant is more likely to be associated with systemic autoimmune diseases. I don't know. People can correct me.
So basically, I think we should investigate. So when we talk of
Episcleritis.
investigation, when we talk of investigation, one is to diagnose an underlying autoimmune condition. That is one. The second is you are also doing baseline investigation, because assuming that
For
suppose 3 days
immunosuppression.
down the line they require immunosuppression, then you again are we have to do SGOT, SGPT or LFT or whatever. So in that direction also one should get the baseline workup done, because the rheumatologists also, they would require to rule out a systemic infection, tuberculosis, so many things before they'll give a systemic steroid or whatever. So, one is diagnostic to underlying disease. The second is pre-treatment or for immunosuppression, some basic workup. It's better to do it because we don't know who will respond, who may not respond. So it's better to get it done and start treatment and advise it, and the next follow-up you can see whatever is,
Yeah. So in the first day you advise them the
I think so
investigation.
it's better. Yeah.
Nikhil, I just wanted to ask, sometimes we see these systemic viral infections or chikungunya and all these conditions, and they just have one simple episode of scleritis. So how do we really manage them?
If there is a known viral association, we don't have to do the investigation. Same thing goes for trauma, same thing goes for HSV, same thing goes for acanthamoeba. So the question is, when you don't have a clear-cut association to point at the infection leading the scleritis, then you have to do the systemic investigation. Like Anaga is asking, if it is a mild case or a first-time case and you are seeing just a patch, will you investigate or not? So first of all, being a tertiary referral institute, that kind of cases are kind of rare. Normally we get it, the ones which don't respond to steroid, the ones which are already started having necrosis and things like that. But in my opinion, the scleritis is the manifesting feature of an underlying autoimmune problem which is small or big. It may not be big enough to manifest in the blood test, but something is wrong with the patient as an individual and not the eye alone. So I think both for treatment and medical legal purposes, scleritis needs to be investigated not only by us but by the rheumatologist also. And like Dr. Nikhil rightly pointed out, we are anyway going to start immunosuppressive treatment, which are potentially toxic medications. So from that angle also, this investigation will help.
Okay, now suppose you have started the patient on topical steroids and oral NSAIDs, call the patient after 1 week. At what point of time would you switch the patient to oral steroids?
So if the response is there to these two, we can even wait, like Dr. Nikhil said, without a tissue necrosis, you can wait for as long as you want. Scleritis sometimes even same is good. If there is no deterioration, if it is just maintaining, it's not a disease which gallops and improves day by day. So even if the patient is status quo in terms of the symptoms and signs, and there are no fresh patches, satellite lesions, or if there is no melting of the sclera or no increase in the symptoms, then you can wait and watch. In this context, it is extremely important that we need to give supportive treatment also. If there is anterior chamber reaction, you have to give a cycloplegic. There may be trabeculitis, you have to give anti-glaucoma treatment. Those are the things which may be adding to the symptom of the patient rather than the scleritis itself, because it is a holistic globe inflammation. So you need to take care of the anterior chamber inflammation, the glaucoma happening because of trabeculitis or steroid response. Those things also have to be kept in mind. But if the symptoms are increasing or if the sclera is showing melting, then you need to, gear up your treatment to the next level.
If the patient is status quo, he'll come back and tell you nothing has changed, it has not improved, even though we know that it will take time. So how do you counsel the patient at that point of time? Because
So
he
we
will say
need to
nothing
tell them.
happened.
So we need to tell them that even in a systemic context, even if you start a systemic treatment, and immunosuppression is going to take about 10 days to 2 weeks to act. If you give oral methotrexate, it doesn't act the next day. So it is going to take 2 weeks to act. And the topical steroid would have given them some relief. So we have to counsel them that this is a disease which is reflecting your body and not your eye. And the steroid, which is the early onset action medication, has taken some effect. It's going to take some time for the inflammation to come down, whether or not you use the medication. And I use this line on them that don't look at the fact that there is no improvement, that there is no deterioration itself is a plus point, provided they don't get lost to follow up after that kind of advice.
Right. Yeah. So, Dr. Sayan, would you start the patient first on systemic steroids, and if it doesn't improve with that, then go on to other immunotherapy?
Well, most patients with scleritis, depending on how severe the inflammation is, would require systemic medications. Maybe there's a certain proportion of patients who would respond to topical steroids only, but they are the ones who usually come back with recurrences, etc. So scleritis is an opportunity when the patient presents with scleritis and scleral inflammation. It's an opportunity for diagnosing in that window the underlying condition which is causing this, unless it is extraneous or it's infectious because of either surgery or this and that. And that needs to be, you need to have one eye on that while you're treating the condition. And initially, you start with frequent topical steroids. If that is not controlling the inflammation, you add systemic NSAIDs, systemic steroids. And once you have a handle on what the underlying diagnosis is, then the systemic immunosuppression is usually, um, targeted at what the underlying condition is. So if somebody has rheumatoid, then you need to give systemic therapy that will address the underlying rheumatoid arthritis. If somebody has GPA, then that needs more intensive immunosuppression. You might start with something IV. If somebody has scleromalacia, you need to start with something intravenous, much more higher bolus dose. So the immunosuppression that you use is once you have a handle on what is causing the scleral inflammation. Otherwise, you're just treating essentially the ocular manifestation of the systemic disease. The immunosuppression, which is going to stay long term, it's not as if you're going to give immunosuppression for 4 weeks or 6 weeks. Patient will be on it for a while. And that is targeted more at the underlying systemic disease.
One of the problem, Anaga, that I commonly see with general ophthalmologists, that they would start systemic steroid. Then they would taper it probably a little faster than recommended by rheumatologists or people like that. And then the scleritis starts coming back again. Then they again confuse what to do. Sometimes they step up, again step down, and this goes on, and then they tend to refer. So what I feel is that a patient who needs systemic treatment or systemic steroid will require a second drug to maintain the effect. So the steroid is only going to initiate the sort of remission, but they will need a second drug. So I'm not sure. I feel as an ophthalmologist we should involve a rheumatologist right at the moment when you feel that okay, you start a systemic steroid, then send him to a rheumatologist who can start a second drug based on severity or the underlying diagnosis, and then you can probably co-manage the patient, because invariably, like I sometimes see somebody is given steroid and then there's big confusion of what is happening because it keeps coming again and again, and they don't know where to go, and then they refer it.
Yeah, so the take-home message is after the first week, you get the investigation done, and if the patient is not responding and you feel the need to start systemic steroids, immediately refer to a rheumatologist so that then you can co-manage. Right?
Dr. Annaka, there is one more problem also. Dr. Nikhil touched upon a very important point where the quick taper, we are all used to, tapering every week and stopping steroids in our, setups. So that also, I've seen the rheumatologist and my uveitis colleagues sometimes continue that 5 milligram dose for a very, 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 very long time, provided diabetes and everything else is under control. So that's one thing. The other common mistake that happens is that people are hesitant to give steroid because they may upset the, metabolic conditions like diabetes. So they don't give the adequate dose. They will give a baby dose or a half dose or a mosquito dose, which attracts only the side effects and not the main effect. So if you have to give steroid, provided you have a clearance from the physician, you have to give the full milligram per kilogram dosage. Otherwise, the inflammation will not come under control. You will attract all the side effect of the steroid. You will not get the main effect of the steroid at all.
Right. Absolutely. Dr. Pranav, would you like to add anything?
Yes, ma'am. So as all of us have been discussing, that you need to really segregate whether you need to be aggressive in your management based on whether you have a necrotizing one or a non-necrotizing. And I personally believe that starting a topical steroid, adding an oral steroid or an oral NSAID, seeing the response in a non-necrotizing, which is very not so aggressive situation, you have time not only to investigate but also to try your management therapy. If you don't see a response, then you definitely need to consider the systemic immunosuppressants. What is the most concerning is that the patient resolves. Suppose the patient resolves from your primary treatment. We are not really sure. If they have a recurrence, then the question comes about, are we going to put them on a maintenance immunosuppressive along with the primary steroid therapy or not? So because most often than not, these scleritis patients do come back with recurrences, and they will have patches either in the same eye or maybe the contralateral eye. In those cases, we need to then reconsider about putting these patients on a maintenance drug. Now, the drug of choice for maintenance, you need to really collaborate with your rheumatic friend, rheumatologist, because that is very important. We know it's a notoriety of recurrence in these situations, and the patients do expect them to be put on something which is not having many side effects like the steroids. So this is where the rheumatologist does come into a big play.
What if the patient is a steroid responder? How would you manage?
So I personally feel the ones which an ophthalmologist can fairly and safely play around with is methotrexate. And it has worked. It has worked. It is been used historically for treating systemic connective tissue disorders. So therefore, it's always important that an ophthalmologist can definitely try and play with methotrexate, see for the response. If he doesn't see a response as expected, he can definitely collaborate with the rheumatologist for certain better drugs. Now, right now, the biologics that are available are working miraculously in many of the systemic conditions. So we should not hesitate to consider some of these now. And these have been used quite extensively now without much of systemic side effects. So a collaboration with the rheumatologist will definitely get us through with a lot of maintenance drugs.
I think Dr. Radhika ma'am just messaged that she has.
It's
Thank
been
you
a
so much,
wonderful
ma'am.
discussion. Thank you so much. I think we can go on and on forever. And, loved every minute of it. Sorry, in the fag end, I cannot be there because of the other commitment. So I'll catch up with you, probably after the meeting on the bullet points that I missed out. Thank you so much, Anaka.
Thank you so much, ma'am. Thank you so much. So I was just asking Dr. Sayan, if the patient is a topical steroid responder and 1 week later or 10 days later you see that the IOP is rising, then what would be your change in the treatment?
Give systemic steroid.
So, and topically, would you shift him on loteprednol or something? Would that work at all? Or you just give systemic?
For any patient who is a steroid responder, is showing an intraocular pressure response, but needs steroids, you can always give them systemic steroids if they are, based on what is the level of inflammation and what are the systemic comorbidities. If it is very severe inflammation, you can give them intravenous also. Systemic steroids do not elicit so much of a steroid response as topical steroids.
No,
So,
the other
Dr. Nikhil,
problem
if you
comes
can.
about diabetes.
Yes,
Many of these
yes,
patients have bad diabetes.
yes.
So we need to be sure that if we are starting steroids, then we involve the diabetologist or physician, whoever it is, because otherwise, the blood pressure, sugar, and everything goes for a toss. So we need to be, we need to tell them, because sometimes that is whether to give steroid if he's diabetic, uncontrolled, is again a thought process which is always there. Makes
Right.
it difficult to treat. Like a steroid response in the eye, you said, if there's
Yes.
bad diabetes, then to give IV steroid, oral steroid, again a big problem for physicians as well.
Right. And what are the trigger factors for these patients? When do they get those recurrences? Is there any trigger, and can you counsel them to say in what way? Many times they ask, what can we do to prevent these recurrences? Dr. Nikhil, what do you think?
I don't think there is really a identifiable trigger like that, but the only thing is that the underlying disease may not be under good control. So for example, you can have a patient with autoimmune disease where the patient will tell you my joints are okay, my everything else is okay. You're telling, I have had situations where the patient not willing to believe that this is an autoimmune or this is related to your systemic disease. So we have to tell them that the disease can activate at different areas of the body at different periods of time for reasons that we don't exactly understand, and we need to control the disease process, otherwise the eye will sort of not sustain, or we are likely to lose the eye. So because sometimes very difficult to tell them to take immunosuppression, they're not willing actually,
Right.
because they're very scared once you tell them that you have to suppress the and take all these drugs. They're not willing.
Absolutely. Absolutely. Is there any other point anybody would like to add as a take-home message for all our viewers? A general ophthalmologist seeing episcleritis and scleritis, one from each of you. Dr. Parul, a take-home message for her.
So I think we have come to this thing common consensus that we should be treating with NSAIDs, oral and topical, and not start steroids, and investigate if you are finding more number of recurrences. And scleritis, I think we need to treat it more aggressively. Non-necrotizing variety, I think I start with topical and see the response. And with necrotizing variety, obviously you have to be very aggressive in terms of investigation and management.
Yeah. Dr. Pranav, one message as to when to refer for the general ophthalmologist.
I feel some scleritis could be a hint towards a systemic disease, and I think we as an ophthalmologist should not ignore this aspect. Just because we get once you have diagnosed it as scleritis, it's very important that you definitely rule out any systemic associations, because it could be a highlighting point to tell you that there's something wrong systemically. And as an ophthalmologist, just because we got a good response to a steroid doesn't mean we leave it alone. It's always better to convince the patient, speak to the patient, and get an investigation done to probably pick up an early changes of systemic disease. I think we should not ignore scleritis with that aspect.
Dr. Sayan, anything that you would like to say as a concluding remark?
No, like I mentioned before, it's important for everyone to know how to differentiate episcleritis and scleritis. Episcleritis is fairly innocuous. Recurrences are not that important. Usually not so common, even if they happen. They are easy to treat. Patients are usually not symptomatic. It's not a serious condition, and we don't, in most cases, need to investigate for anything. It's important to know how to differentiate scleritis from episcleritis. Like I said earlier, scleritis is a very serious condition, and you need to send the patient to somebody who can take advantage of that window of opportunity to diagnose the underlying condition which is causing the scleritis, which in itself requires treatment for the patient's quality of life and also to save the eye, because the potentially life-threatening condition. You may get away by treating scleritis a few episodes by just using topical steroids very frequently, or by giving NSAIDs orally, giving steroids topically or systemically, or giving systemic NSAIDs. But because it is a manifestation of an underlying autoimmune disease mostly, it will keep recurring, and it can cause a lot of morbidity in the eye. And you should send that once you know this is scleritis. I don't see, for general ophthalmologists, what is the point in wasting the time unless the patient can't get to a specialist. Send the patient to somebody who can treat that, to somebody who is more conversant with ocular immunology, either a UVA specialist or anti-segment specialist who deals with these kind of immunological conditions.
Dr. Nikhil showed two, three very good slides about the management. If you can just probably go over it so that we can.
Okay, one second.
Yes.
I'll just go through them.
Yes.
So as I mentioned, that if it is a necrotizing variety, then normally they need immunosuppression. The fastest acting immunosuppression is with pulse steroids, which are given IV, and then cyclophosphamide, which is quite a strong drug, but fairly cost effective and very potent, can be used. And then you have secondary drugs like methotrexate, mycophenolate, and other drugs. And in patients who are not responding, you can use biologic drugs, as we mentioned. Again, all these you have to do in conjunction with the rheumatologist. Another important point I wanted to stress is that if the general ophthalmologist does try to manage these conditions, maybe in places where there are no specialists, then you need to tell your rheumatologist what you need, whether you need emergency immunosuppression, or the patient has a disease which is not very severe and you can sort of manage with oral drugs, or you want IV pulse, or what sort of immunosuppression you require. That is again something that you need to use. And nowadays there are a lot of also some articles on use of JAK inhibitors, which there people are using in some forms of refractory scleritis. Also, that there is an option of using a triamcinolone. For example, I've had these type of patients where you could not step up the systemic immunosuppression because they had some sort of systemic problems, and they had non-necrotizing varieties of disease, and I just managed to add a little bit of triamcinolone conjunctivally, little away from the nodules, and they tend to get better. This was another patient with sarcoid who was not improving despite systemic treatment, and maybe a little bit of steroid has helped. But again, we need to be very cautious, because if there is necrosis, any injection can cause a perforation. So just avoid that. And this was one of the very good articles on systemic immunosuppression, which has been authored by Dr. Sayan and Dr. Anahita, which talks of how we should use these drugs in a variety of ocular surface conditions, including scleritis. So as I've mentioned, if you have anterior scleritis, we need to do a systemic workup to rule out a connective tissue disorder. If there is a specific disorder, of course, then we treat it, because we know which drugs will work for that particular condition. The rheumatologist will be aware which drug works for, say, a particular condition. So you treat it directly, specifically. However, sometimes when the results are all negative, then if you're looking at a patient who has anterior scleritis, which is non-necrotizing, could be diffuse or nodular, then as we mentioned, we can give oral NSAIDs. If the patient is improving, continue it for 6 to 8 weeks. If the response is poor or it's not improving with oral NSAIDs, then you will have to look at systemic treatment. Because these are not very severe cases, maybe oral steroids with methotrexate or azathioprine can be used. However, if you have patients who have necrotizing scleritis, as we mentioned, they also recommend giving IV immunosuppression followed by oral maintenance. So these are the oral maintenance drugs they have mentioned. If the patient does not still respond, then you would use the reserve drugs, which are the biologic agents, or maybe rituximab, infliximab, and there are a number of articles from Shankar Nethralaya and other places where they've successfully used this drug. So you basically have a flow chart where you need to distinguish whether it's necrotic or non-necrotic. Non-necrotic, use oral NSAIDs and steroids. Not responding, give systemic oral treatment. And if it is necrotic disease, then you use directly quick-acting IV drugs, steroids, and maybe cyclophosphamide, and then maintain them on other agents, and of course use the reserve drugs like biologic agents and JAK inhibitors if they are non-responsive. So this is the sort of flowchart which they've mentioned, which is quite comprehensive. But then we have to decide whether we are comfortable with all these options. But I think very often, even from rural areas, sometimes these patients are referred. So at least they can start up the workup, they can start up some rheumatology evaluation and start the basic treatment and then refer it to a higher center, so that the patient doesn't lose time that way.
Excellent. Very nicely put and very nicely summarized. I think that was by Dr. Sayan. That
Yeah,
flow.
yeah.
Yeah.
Their group have.
Very nice, very nice. Is there anything else that we yet need to discuss in this? Or we
I
have
just kept
finished?
some pictures of things which mimic scleritis, but
Okay, yes. You can just.
sometimes you can. Yeah, so
Mm,
it's my own
correct.
mistakes, for example, where I realized this was not scleritis or something. One of the very common things that can happen is for example, you can have patients who have tumors. So for example, this is not one of the patients, but I had a patient who had a lesion like this very early in my practice where I had limited experience, and I kept treating him with oral NSAIDs and steroids, and he was not getting better for a long time. And then I told him that you have to send you to LV Prasad because I can't understand what is happening. And because he denied that he had any systemic problem, and then subsequently he told me he had a lymphoma which was undergoing treatment. So this was actually the patient had a lymphoma and which had come to the eye, and there was a subconjunctival red eye with a mass lesion. So sometimes the patient does not tell you what is going on systemically, or sometimes it might just be a localized ocular involvement without any systemic disease. This was one patient who had what looked like a scleral nodule was actually an OSSN or a neoplastic sort of lesion. So we can get these type of masquerades. And this was one patient very early on in my practice where the patient had retinal surgery and then scleral necrosis. And I was wondering what this was. He was a diabetic patient. He was an amputee. And basically, I just did a rotational conjunctival flap, and the bare area here was covered with an amniotic membrane, and he recovered, and his systemic investigations were all negative for any autoimmune condition. So sometimes we do get these type of masquerade lesions. The other lesion that sometimes we can also see is patients who have rhinosporidiosis, though it's not very common in our part of the country. I think South India maybe they see a little more. Again, beta radiation is not now seen, but I've seen some in the early phase. Another condition which is very often missed by most of us is a scleral plaque. So a lot of elderly people, when you look carefully, they have a scleral plaque which is sitting under the conjunctiva silently. But sometimes when it starts extruding, there is inflammation which looks like a scleral sort of picture, and they often get extensively investigated. So basically, it's just the plaque which is sort of coming out from the sclera onto the surface just needs to be removed or sometimes covered with a patch, and it's not an autoimmune condition. Similarly, patients with mitomycin C, we need to be sure that they don't have a mitomycin C induced necrosis rather than a systemic. So some of these conditions are to be kept in mind, and sometimes very severe flictins can also look like scleral inflammation, though they respond much quicker, but they sometimes will again need systemic investigation. So these are just some of those cases which make you get confused and treat.
Yeah. Very nice collection, and I think very nicely elucidated. Thank you so much. I think it was a great discussion, and so much in detail about episcleritis and scleritis. I think it's a very good guideline for all our viewers. Is there anything that you would like to add, or we would conclude?
Yeah, I think so.
Thank you.
Thank you.
I
Thank
think
you
it
so
was-
much.
Thank you so
Thank you
much,
so
Dr.
much.
Nikhil, for all the efforts. And you really made a lovely presentation and showed so many slides of so many masquerades also. Thank you so much to our esteemed panelists, Dr. Sayan, Dr. Parul, Dr. Pranav, and Dr. Radhika ma'am. And thank you for the time and for your inputs. It's been really a very enriching experience. On behalf of Team Maharashtra Ophthalmological Society. Thank you so much, everyone.
Thank you. Good night.
Thank you. Good night.
Thank you. Thank you, Numerotech, for all the support. Thanks. Bye.